So we wanted to present some cases that are illustrative of how this might roll out in the real world. So here we'll discuss one of these patients. This is a woman who's age 54, probably postmenopausal at the time of diagnosis, node status N1, so worrisome, 2 out of 10 nodes are positive here. Tumor size is 1.3 centimeters, grade 2, really robust ER expression, but a loss of PR expression, always worrisome, HER2 negative. And she has some symptomology, severe joint pain, mood swings, etc. And she gets the BCI test ordered around this 5.5-year time frame, probably suggesting she had 6 months of chemotherapy, gets endocrine therapy for 5 years, etc. So this is a pretty typical patient in that regard. And here we have a patient who has a no result. H/I score is low, so that's a no result. And that predicts that there is no benefit from extending endocrine therapy. And so when you get the report for this patient, you get the dichotomous result on the top, and on the report on the bottom, you get the actual number or the rate of possibility of recurrence beyond those first 5 years. And despite having started off the day with a relatively sort of yucky scenario, node positive, youngish, ugly looking PR status, etc., she's got a low risk of late distant recurrence, 1.9%. So this is a patient that I think many of us might knee-jerk say, hey, you're in a bad situation, we've got to extend you. Yet this is a woman that's not going to benefit from that, and in essence is only going to be left with the harms of extending endocrine therapy. I'm sure, I've certainly had these patients. Have you seen patients like this in your practice?
Yeah, definitely. Very recently, in fact. And, it takes me back to when she was initially diagnosed, the entire focus was on whether or not she really needed chemotherapy or not. So we sent an oncotype, and thankfully it was low, hooray, even with 2 positive nodes, she doesn't need chemo. But then over the next, 5 years, she's on endocrine therapy, which really changed her life. She gained 20 pounds, aching all the time, felt old, so really didn't want to be on it, but she would have continued on it. But we sent BCI and got a result that was very similar to this, and she was just, thrilled, and we both felt confident about taking her off.
Thank you. So I'm going to just walk through a couple more data slides. So I think, like I said, one thing that we always worry about with our node positive patients is that they are at high risk, not just at early recurrence, but potentially at late recurrence. And here we have patients that I think we look at and go, gosh, you're high risk. Yet when you look at them at a genomic level and look at this expression level of these 2 genes, a quarter of those patients are essentially low risk and very unlikely to benefit from extending of endocrine therapy, similar to the patient we just discussed. And what does this play out like in one of those studies? So this is a little graphic from the IDEAL trial. So just to walk you through this, in the IDEAL trial, patients were randomized after 5 years of endocrine therapy to extend for 2.5 years versus 10 years of extension, a full 10 years, 5 years of extension. This is a high-risk patient cohort entering this study. There was no randomization to no years of extension. Many of these patients needed chemotherapy. The investigators at the time felt that it was not appropriate to randomize to no years, so it's 2.5 versus 5 years of extension. And what you're looking at here is kind of a yucky flavor of tumor, node positive, large tumors, T2 or greater. Yet when you look at the subgroup of patients from that trial that had low scores on the BCI biomarker, the HRI biomarker, there is no difference between the partly extending and the full extending arms, underscoring what this data looks like in one of the trials when you have that result. So just to also just drill down a little bit deeper on this node positive space, when you look at these trials that we were just talking about, MA17, TransAtom, IDEAL, there's a pretty robust representation of patients who have node positive disease. And yet here too, again, if you have the high HRI biomarker, we see a very consistent relative risk reduction of about 2/3, anywhere from 65% to 58% to 71%. And on the flip side, on the converse, if you have a low score, no HRI result, no benefit for any of those groups statistically. So really all we can do for those patients by exposing them to these drugs for longer is only give them the harms of these therapies. So for the node positive aspect, I think that's one of the parts where people still feel uncomfortable about relying on a biomarker. Our gut instinct is to rely on the clinical pathologic factors, but our gut instincts can be wrong, especially in the face of a molecular feature. So now you see within the NCCN guidelines, us getting more confidence, again, highlighting in the node negative, but also in the node positive patients, this test can be useful, both in the NCCN, but also in the ESCO guidelines. And then just the node positive patients as just what does that look like in one of these trials? So this is from the TransAtom study. This is specifically looking at the node positive patient. Just to remind everybody, TransAtom was an extension study of 5 more years of tamoxifen versus not. And in that trial, we had a positive result for the entire population, roughly about 4%. So put another way, 1 in 25 patients is going to benefit. And in this subset of the node positive patients, that was really reflective from this validation cohort of being the same in the other. And then when we look at the breakout by the H/I biomarker, in the low H/I biomarker cohort, if anything, it was going in the wrong direction, right? You can see it going down below. And then there was a complete enrichment for the patients who are going to benefit from this extension in the in the H/I high biomarker group with the YES score. And when you look at the hazard ratio here, relative risk reduction, again, 2/3, 67%, and a number that actually tilts in the wrong direction for the low patient group.